When severe heat damages tissue, the destruction doesn't stop at the skin. It triggers an immediate, massive biochemical alarm, rippling across the entire body. What begins as a localized thermal injury rapidly transforms into a massive, system-wide inflammatory crisis. Without immediate intervention, this cascade initiates multi-organ failure. Clinicians must actively track and treat a rapidly shifting physiological target, rather than simply managing a static wound. This timeline dictates the matrix of care. It consists of 3 distinct, overlapping phases: emergent, acute, and rehabilitative. To keep a patient alive, a medical team must stabilize the cardiovascular system, combat extreme metabolic exhaustion, and restore physical function in exact sequence with the body's changing chemistry. Focusing only on the visible tissue damage ensures complete systemic collapse. Survival depends entirely on predicting the internal timeline and outpacing it. Before entering the first phase of care, clinicians must calculate 2 critical variables that dictate all subsequent treatment algorithms: the depth of tissue destruction and the extent of the surface area involved. This diagram shows human skin layers. Clinicians categorize severity by measuring how deeply damage penetrates the non-vascular epidermis down into the vascular dermis and subcutaneous tissue. In a partial thickness or second-degree burn, heat destroys the entire epidermis and portions of the underlying dermis. Because dermal nerve endings remain viable but exposed, these injuries are excruciatingly painful, forming fluid-filled vesicles. A full-thickness burn, 3rd and 4th degree, indicates the total, irreversible destruction of both the epidermis and the entire dermal layer beneath it. Paradoxically, the deepest burns cause 0 pain in the central zone. The intense heat completely incinerates the nerve fibers, leaving behind a dry, leathery, and often charred layer of dead tissue known as eschar. Because the vascular and cellular matrix is destroyed, these deep wounds cannot spontaneously re-epithelialize. Identifying a full thickness depth immediately flags the patient for mandatory surgical excision. The second baseline variable is the total body surface area, or TBSA. This measurement determines the magnitude of the systemic inflammatory response and dictates exact fluid resuscitation volumes. In adult patients, clinicians rapidly estimate TBSA using the rule of 9s. This triage tool divides the body's surface into distinct anatomical regions, each representing roughly 9% of the total area. This Lund and Browder chart provides the mathematical precision required for specialized care. This is an absolute necessity for pediatric patients. As a child ages, the surface area proportions of their head and legs change significantly, requiring exact mathematical compensation to avoid lethal miscalculations. By intersecting the depth grading with the precise TBSA percentage, the clinical team locks in a specific mathematical algorithm that will predict the patient's entire trajectory of survival. That trajectory begins at minute 0, the emergent phase, covering the first 72 hours. The immediate structural threat is structural. The burn triggers inflammatory mediators that attack the vascular system, forcing the tight junctions of healthy capillaries to open and become highly permeable. Blood plasma, electrolytes, and essential proteins rapidly leak out of the intravascular space and directly into the surrounding interstitial tissue, generating extreme, rapid-onset edema. As the vessels empty, the intravascular void causes cardiac output to plummet. Blood pressure crashes, and the patient enters profound hypovolemic and distributive shock. Simultaneously, massive cellular destruction releases toxic levels of potassium directly into the bloodstream, creating a lethal chemical threat known as hyperkalemia. The fluid shift also creates a devastating mechanical threat. As expanding edema gets trapped beneath the unyielding, leathery eschar, it acts as an internal tourniquet. This crushes underlying vessels and strangles distal blood flow, causing acute compartment syndrome. In these first 72 hours, the medical team runs a brutal physiological race. They must actively prevent total vascular collapse and stop structural tissue strangulation. The absolute clinical priority during phase 1 is massive, immediate intravenous fluid resuscitation. The goal is to artificially maintain organ perfusion by constantly replacing the plasma while the capillaries continue to leak. Clinicians strictly calculate the necessary intake volumes using the initial TBSA and body weight assessment formulas. To gauge whether resuscitation is successful, nurses monitor a primary physiological marker. They titrate the IV fluids to maintain a continuous urine output of 30 to 100 milliliters per hour.
They also monitor for myoglobulinuria, a condition where dark red urine indicates severe muscle breakdown. If myoglobulin is present, even higher fluid volumes are required to flush the kidneys and prevent acute renal failure. If acute compartment syndrome occurs, surgeons execute a definitive mechanical countermeasure, the escharotomy. They slice a linear incision directly through the dead eschar to release the crushing pressure of the underlying edema. This aggressive fluid and surgical management continues until the capillary integrity spontaneously restores itself, halting the hemodynamic freefall and ending the emergent phase. At the 72-hour mark, the physiological landscape pivots, initiating the acute phase. The defining characteristic of this phase is a complete reversal of the fluid shift. The capillaries repair their junctions, causing trapped interstitial fluid to surge violently back into the vascular space. This sudden intravascular return triggers profound intrinsic diuresis. The kidneys must immediately process and flush out the massive volume of reabsorbed fluid. With the immediate shock resolved, a new secondary systemic threat takes hold, the onset of a profound hypermetabolic and hypercatabolic state. The exaggerated inflammatory stress response sends the patient's resting energy expenditure skyrocketing. The body drastically increases its demand for both oxygen and baseline nutrition just to maintain basic cellular functions. The patient has barely survived the drought of hypovolemic shock, only to immediately face the rapid, consuming exhaustion of a metabolic overdrive. Surviving this hypermetabolism requires aggressive nutritional combat. A severe burn patient's daily caloric demands can hit an astounding 5,000 calories. The body requires immense, high-protein and high-carbohydrate fueling. This frequently demands immediate enteral tube feeding to prevent the body from aggressively catabolizing its own lean muscle mass for energy. While the body is fueled internally, the external clinical priority shifts to relentless infection control and achieving permanent wound closure. Treatment pathways diverge based on the initial depth assessments. Partial thickness burns may successfully heal using daily applications of topical antimicrobials, like silver sulfadiazine. Full thickness burns demand a much more aggressive protocol, the early surgical excision of the necrotic eschar. This physical removal of the dead tissue eliminates the primary source of the inflammatory mediators driving the systemic response. To permanently close the excised wound, surgeons use biological grafts. Autografts, which utilize the patient's own healthy skin, are the definitive solution, while homografts from human donors or xenografts from animals serve as temporary biological shields. Mastering the acute phase requires a precise balance. The medical team must sustain aggressive nutritional fueling while executing rapid surgical closure to outpace the ever-present lethal threat of sepsis. This table outlines the final stage of care, the rehabilitative phase, which formally begins once the major wounds achieve closure. With the patient's acute survival finally secured, the nursing priorities turn entirely toward long-term physical and psychosocial restoration. The primary physical threat in this phase shifts to the microscopic level, driven by abnormal collagen maturation and destructive scar formation. Abnormal healing presents in two pathological forms. Hypertrophic scars are hypervascular, red, and raised, but remain strictly within the original wound boundary. Keloid scars, however, are nodular and aggressively extend beyond the original margins. To counter this stiffening tissue, nurses enforce aggressive physical interventions. This includes the mandatory use of continuous compression garments, strict range of motion exercises, and continuous splinting to prevent debilitating joint contractures. A perfectly healed wound offers no functional value if a scar contracture permanently paralyzes the underlying joint. Physical therapy is a rigid medical necessity. Burn trauma is uniquely devastating to the mind, frequently resulting in post-traumatic stress disorder, severe depression, and profound body image disturbance. True clinical success requires actively guiding the patient back into society. This demands dedicated peer support, long-term psychiatric care, and comprehensive vocational rehabilitation.
Successfully managing a severe burn injury demands a clinical team that can flawlessly transition across an evolving timeline. They must navigate the fluid calculus of the emergent phase, survive the surgical gauntlet of the acute phase, and commit entirely to the lifelong functional restoration of the rehabilitative phase.